Good morning. Welcome back to Open School. In the last session, we have discussed about the pathophysiology, etiology of mitral stenosis. Mitral stenosis typically progresses slowly over 20 to 30 years, and the initial symptoms become worsened and becomes envisaged a class 3 or class 4 with the development of atrial fibrillation. And today we will be discussing about the clinical features of mitral stenosis. The patients usually remain asymptomatic until the mitral valve area is less than 2 cm square. The normal size of the mitral valve is approximately 4 to 6 cm square. The most important symptom is breathlessness. We have discussed the mechanism. It is mainly due to reduced lung compliance due to chronic pulmonary venous congestion. That is, with the development of mitral stenosis, LA pressure increases, that is transmitted to the pulmonary venous system. And patient comes with dyspnea on exertion, orthopnea, and episodes of paroxysmal nocturnal dyspnea. Second important symptom is fatigue. This is because of the low cardiac output. As the valve is stenosed, the left ventricular filling is decreased, and this leads on to decrease in the stroke volume, and so the patient can develop fatigue. As time goes on, the patient develops pulmonary hypertension that leads on to right ventricular hypertrophy and finally the right heart failure. So this leads on to development of edema and ascites. Palpitation is another symptom. This is mainly when the patient develops atrial fibrillation. When the LA enlarges, this leads on to atrial fibrillation. And further complications can also occur with the development of atrial fibrillation. Hemoptysis can occur. This is mainly due to pulmonary congestion and pulmonary embolism or recurrent infections. Cough is common. It is due to the pulmonary congestion or compression of the left atrium on the bronchus, left main bronchus, leading on to development of infections. Chest pain due to right ventricular hypertrophy, leading on to ischemia, can imitate a cardiac pain or the angina pain. Thromboembolic complications develop when the patient develops atrial fibrillation. Around 10 to 25% of patients can present with a stroke or limb ischemia. Other important symptoms you should consider are: one is hoarseness. This is because the left atrium is a posterior-most chamber and the recurrent laryngeal nerve can be compressed when the left atrium enlarges. This is called the orthopnea syndrome. Persistent cough. Enlarged left atrium compresses the bronchus, and this can lead on to persistent cough. And these are the major symptoms. Now we go to the examination findings. Mitral fasciitis is not seen in our people, only in fair skinned people. You can get a pinkish purple patches on the cheeks. Then go into examination of the pulse. Usually the pulse is low volume because the stroke volume is decreased. With the development of atrial fibrillation, you get irregular pulse. Then coming to the palpation or JVP, going to the JVP, the A waves will be prominent when the patient has got a pulmonary hypertension. With atrial fibrillation, the A wave becomes absent. Then epispeed. The epispeed is tapping. This is a classical finding. Tapping epispeed is the palpable counterpart of the loudest one. Loudest one is one of the characteristic finding that you get in mitral stenosis. Then you can get the palpation left parasternal heave, and sometimes the P2 component may be palpable in the second intercostal space. So these are and a mitral diastolic rumble may be palpable. The diastolic thrill can be heard but felt in near the apex. Now going to the auscultation, the characteristic auscultatory findings are shown here. So S1 is loud. Because of the increase of this is the exact mechanism will be discussed later. Remember that S1 is loud. The main reason is because of the development of a pressure gradient, that is increased pressure in the left atrium. The mitral valves are in the open position when the ventricle contracts. So this leads on to wide excursion of the movement of the mitral valve. So this will lead on to loud S1 in mitral stenosis. The P2 component of the second heart zone depends upon the pulmonary hypertension. So as the patient develops pulmonary hypertension, the P2 becomes loud and even the second zone may appear single. And with severe pulmonary hypertension, you can get a diastolic murmur, the Graham-Steele murmur or pulmonary regurgitation. Another classical finding is the opening snap, a high-pitched additional heart sounds after the second sound. This interval, that is from the second heart sound to opening snap, is S to OS interval or A to OS interval. This is used to calculate the severity of the mitral stenosis. The longer the A to OS interval, milder is the mitral stenosis. That is, it is inversely proportional to the duration of the opening snap. We will discuss the opening snap in much detail later. Then you can get a mid-diastolic rough rumbling murmur, a low-pitched one with a presystolic accentuation. The presystolic accentuation murmur is due to the atrial kick. So with the development of atrial fibrillation, the presystolic accentuation is lost. So the characteristic murmur of mitral stenosis is mid-diastolic and a presystolic. This is low-pitched murmur, and so it is best heard with the belt of the stethoscope. It is a very localized murmur. It will only with the careful auscultation, especially at the apex, patient rolling to the left. So these are the important auscultatory findings that you get in mitral stenosis. So the details of these murmurs and auscultatory findings are shown in a pictorial representation here. Now we go to the complications. So here you can see the first heart sound, which is loud. This is the second heart sound. This is the opening snap, and here is a mid-diastolic murmur. Then comes the presystolic component. Now we think about the complications. Atrial arrhythmias, especially atrial fibrillation. Systemic embolization, 10 to 25% of the patients with a mitral stenosis develop emboli. Risk of embolization depends upon the age of the patient and presence of atrial fibrillation and previous episodes of embolism. Congestive heart failure, pulmonary infarction, and very rarely infective endocarditis. Recurrent pulmonary infections are also common. So today we have discussed about the symptomatology and the important physical findings. In the next session, we will discuss about the imaging and assessing the severity of mitral stenosis. Hope it was useful to you.